Thank you very much, everybody, for joining the online tumor board of the Asian Geriatric Oncology Society. This is tumor board number 5, and today we have been honored by Dr. Nikhil and his team to conduct the proceedings. This has been found to be extremely useful to our audience, especially because there is hardly any formal real-world case-based discussion on geriatric oncology. Globally, geriatric oncology has become exceedingly important, and even for India, many of the cancers like the lung cancer and breast cancer, more than half of our patients are above the age of 65. So, real-world case-based discussions on geriatric oncology are exceedingly important. With this brief introduction, now I hand over to Dr. Nikhil, who will continue with the proceedings for the day. Over to you, Nikhil.
Thank you, sir. And I thank the Asian Geriatric Oncology Society for this opportunity. I hope I would be discussing some rarer or untouched topics, at least through these two cases. And without wasting much time, I think uh, we'll proceed to a case presentation. Yeah, I think the screen is live now.
Yes, sir.
Yeah, sure. Right. So the first case for today is Miss P, who is a active 70-year-old lady with a good performance status. She was a retired government employee who is currently staying with her younger brother. She is a known diabetic and hypertensive for the last 15-20 years and has been on regular medication for the same. And she was also found to be dyslipidemic for the last 4-5 years, and she was on some statins for the same. Of late, she also complains of some disturbance in falling asleep or the sleep duration, and she takes about more than 5 medicines for all these comorbidities. She was doing well until April 2025 when she incidentally found out a lump in her right breast. She also remembers that she has got some vague bony pains, which was further evaluated by her family physician, who has asked for a mammogram. The mammogram showed a Birad's 5 lesion in her right breast, which was about 4 by 5 centimeters in size. So, with those reports, she has come to a hospital where, with a suspicion of malignancy at her age, we did further diagnostic as well as staging evaluation. A PET-CT was done, which revealed primary in the breast with regional axillary nodes as well as multiple non-regional nodes in the cervical area, mediastinal, as well as abdomen. There were also scattered bony metastases noted. A biopsy of the breast lesion was done, which was suggestive of invasive ductal carcinoma, grade 3, and a further IHC for receptor status was performed, which was strongly positive for ER, 90%, 90%, and HER2 was 2 plus, which was again confirmed by FISH, which was found to be negative. The Ka67 was about 60%. So with this information, I would like to ask Dr. Pradeep, whether you need any further additional investigations for planning oncological management, and what would you plan?
Yeah. Thank you, Dr. Nikhil. Can you go to the previous slide once, please?
Yeah.
So this is, to summarize in 2 lines, it is 70 years old lady with diagnosed breast cancer, metastatic, hormone positive, HER2 negative. Has it been a young patient, definitely would have proceeded with the treatment. Now that she is 70 years old, would like to take few more history points as well as some small assessments, because beyond 70 years, in fact, above 60 years, in fact, we need to do geriatric assessment CGA, which is not possible in a routine clinic to do in each and every patient, particularly in a setup where clinician is really busy and if loaded with the patients. But a minimum of G8 score evaluation will give me an idea whether this patient we can go with uh, standard therapy or will need further geriatric assessment. That's one thing I want to do. Second is the social support. What does she have? And the financial issues. And also, now that she's hormone positive, we are going to keep her on some oral medication. I would like to check the drug interactions of all the ongoing drugs. If there are any existing drug interactions before keeping her, giving her the option of, because we are dealing with a hormone positive cancers, probably CDK4/6 inhibitors. So even in those, I would like to have this minimal evaluation before proceeding further.
Yeah. Dr. Nihanthy, any furthermore oncological tests you would like to do it now or later maybe?
Sir, I also totally agree with Pradeep sir. I think currently, at least in the clinical practice, at least in OPD, G8 score is one thing which I would prefer because looking at the age. And then definitely she'll be a candidate to fit for CDK4/6, or maybe she's a known hypertensive diabetic, maybe a 2D echo prior to start of a therapy and a baseline ECG I would consider in her case. And rest I would definitely ask her, like the financial aspect. And because already in your G8, the weight and the mobility index, everything is covered. So based on that, if she's a fit candidate, I would go with the therapy, sir.
Yeah. So definitely as Dr. Nihandi told, cardiac evaluation as well as DEXA scan if possible, if it is feasible, because we are going to start her on postmenopausal lady and hormone receptors.
So as exactly enumerated, we did not do a comprehensive geriatric assessment for this lady, but at least did some frailty assessment, and she was reasonably okay, and she did not have any history of falls in the recent past also. We performed the bone densitometry prior to the initiation of treatment as well as cardiac evaluation. So as was elucidated by other speakers, we we also asked for some other additional tests, which was a germline BRCA assessment. We also got some additional NGS, mostly looking for any druggable targets. And we discussed the treatment options for her, the various CDK4/6 inhibitors available, along with endocrine therapy. And after considering all logistics, they decided to go for palbociclib with letrozole. And in view of bone metastasis, we started her on bone modifying agents along with calcium supplements. Now, this patient uh, had this sense of clinical improvement in the sense that she had a reduction in bony pains as well as reduction in the size of the tumor to some extent by as early as 2 weeks. And she was clinically doing well. So we continued with the treatment. So about three months later, we got a PET CT done, which was in August 2025, where all areas, including the bones, they had good response. Now, in September 2025, she presented to our emergency room. She was actually transferred from another hospital where the discharge summary was mentioning that she had some sepsis. Her blood culture actually grew Pseudomonas aeruginosa, and she was managed for septic shock. And there was also a documented stress cardiomyopathy. So this is what the information we could retrieve from the discharging hospital records. And at the time of her evaluation initially, she was drowsy, arousable, but she was confused and irritable. She sort of had persistent hiccups. The sugar at that time was 130 milligrams per deciliter. She was tachycardic. She was also hypotensive with mild dehydration. She was needing about 12 to 15 liters of oxygen to maintain SATs of 98, 99%. There were some pooled oral secretions, and she had sort of conducted sounds in her lungs. Pupils were normal in size, reacting to light bilaterally. Plantars were downgoing. So she was not in sort of great shape. Her sensorium was depressed. She was hypotensive. So she warranted admission and she was admitted to ICU. Uh, Dr. Dr. Siju again. So,
Yes.
Dr. Siju, yeah, with that clinical description, can we say that she was actually in delirium, or how do you actually label someone to be in delirium in practice?
And delirium, as all of you know, is an acute onset, fluctuating cause. Definitely, that would be the permanent damage, but there may be an history when we add elicit. There may be an acute onset, then fluctuating cause, in definitely in an elderly patient. So, from the history, there is definitely a source of infection, and it's moving towards a sepsis, septic shock condition. So, definitely, it is definitely a precipitating factor for a delirium to occur in an elderly patient. Also, the patient is having multiple comorbidities like hypertension, then COPD, dyslipidemia, and all. All these factors is in a dilemma because the patient is on the hypotensive side, then the chest having signs, then sugars are fairly under control, but there are other signs of systemic this one very systemic decongestion state. So it's a high chance there is a probability of delirium. So in that, so we should first of all, definitely we should start on broad spectrum antibiotics. Then on this underlying dehydration should be assessed. The BP should be normalized. Sugars should be controlled. Then the chest signs should be assessed daily. Then reorientation techniques all should be followed up.
Yeah. Dr. Karishma, if you can enumerate some of the common causes for delirium in elderly.
Hello, everybody. As Dr. Siju already mentioned, the common causes of delirium remains infections. That is most commonly lung LRTIs, so pneumonias and urosepsis remains the most common cause. Now, in this elderly with a good performance status and patient is taking a lot of drugs also, 5+. So polypharmacy is one of the risk factors for developing delirium. Another very important risk factor is frailty and past hospitalization. So past hospitalization, frailty, and malignancy. So these are all risk factors for delirium. And another thing, these are the common causes. Do you want me to
No, I'll just,
the
yeah.
assessment scales also?
No, I'll just ask. Yeah, Dr. Praveen, if you are there. So our patients, elderly cancer patients use a lot of pain medicines, maybe opioids in some of them. And we sometimes get to see patients at the initiation of opioid analgesics. Some of them, uh, or
Yes.
maybe a few land up in emergency room in sort of confused state. So what do you think are the risk factors, or what precautions do you take whenever you prescribe opioids in elderly?
Yeah. Thank you, Dr. Nikhil. Yeah. Basically, elderly population, especially more than 65 years patients, more predisposing or precipitating to the delirium, even though there is no pathological condition, because of the decline of the physiological reserve, they're more prone to the delirium. Like very common problems like constipation, urinary retention, infections, change of atmosphere, any new acute medical conditions, so dehydration, pain. So anything will leads into the delirium. And another challenging issue for the pain management in elderly population is because most of the opiates will cause the confusion, delirium, and the all sedation that leads to the falls and injuries. These are the most common problems when giving the opiates in these populations. But if the patient, suppose the patient has cancer patient, very severe pain, we have to give the opioid medication. So we need to do the extreme precautions while prescribing the opiates, because almost 25 to 50% of the dose reduction compared to the adult population generally we used to start, and always use small doses with long intervals between the doses. The most important thing, educate the patient if he is good in a condition, or educate the patient family about the uses of the opiates, what are the transient side effects, what are the irreversible side effects. That education and training is most important, and moreover continuous monitoring and continuous assessment of the symptoms or side effects associated with the opiates are more important things. So if
Indeed.
if you take all these precautions, definitely we can
give the opiates in a safer way to avoid the complications like confusion, delirium, and the falls and everything.
Yeah. Dr. Dharshitha, if you are here,
Yes, sir. Yeah.
are there any assessment scales for, for the delirium? Yeah.
Yeah. So good evening, everyone. Yeah. So the way I look at is the more frail and more vulnerable the patient, it's a very small insult that can tip off and trigger delirium. With somebody who is more robust, the insult, the relevance of the insult is really large insult that can, trigger and tip them off and predispose them to the delirium. So coming to the assessment scales, the very commonly used tool that I use on most of my ICU patients is SCAM, confusion assessment method, where look at all the parameters. If there's any acute onset fluctuating course, if there's any disorientation, what is the level of attention. So CAM is still fairly sensitive tool across all the settings in the ward or excuse me, sorry. And of course, in the ICU, we can go for CAM ICU, but in the ward, the patient is not intubated. CAM is still a very useful tool to screen. And for level of attention, and so I do generally would prefer using Richmond agitation sedation score, sir, to assess the level of alertness in them. Yeah.
Okay. Yeah. Okay. So I think we have fairly covered delirium in elderly. So it's actually defined as an alteration in attention, consciousness, and cognition with the fluctuating course, and sometimes may be associated with psychomotor behavioral abnormalities, which is actually not explained by the pre-existing or the underlying neurocognitive disorder. We have also seen that the higher the age, prior hospitalizations or the post-operative status, pre-existing neurological conditions, multiple comorbs, multiple medicines, all these predispose patients for delirium. And as was said earlier, that it tries to look into the various factors which can be corrected, like that of the hydration status, source of infection, drug chart, and depending on whether that's a hypoactive or hyperactive delirium, we try to manage our patients if at all need some low doses of antipsychotics, and then maybe do some sort of brain imaging or brain evaluation to find out if there are any other causes. So this is what we do in clinical practice also. Right. So what happened to our patient is that she was admitted and necessary investigations were sent. She was started on broad spectrum IV antibiotics, and after fluid challenge, she was initiated on inotropes. The basic blood works has come. Serum procalcitonin was slightly elevated. The electrolytes, calcium, ammonia, and ABG were decently okay. There was leukocytosis, while the rest liver function and renal function tests were normal. We have repeated blood and urine cultures. Since there was documented stress cardiomyopathy, the cardiac evaluation in form of ECG, TROPI, and 2D echo were fairly okay. A bedside chest X-ray was done, which was nearly normal, and we wanted to rule out if there was something acute which happened in the brain, like that of a bleed, but there was luckily no bleed, and at least on a plain CT, we could not make out any metastatic or mass lesions. So working diagnosis at that point in time was sepsis with septic shock and the encephalopathy for the neurological status. We thought probably it was septic or something more to it, or maybe multifactorial. And later that part of the day, after a neurology consult was done, he asked for some of the additional investigations like electroencephalogram as well as a contrast MRI brain. And he was having another differential of this carcinomatous meningitis, which of course was one of the favorite differentials for neurologists at our place. And we are also thinking on doing a CSF analysis if nothing has been picked up on these for these set of investigations. So 24 hours later on the next day, there was slight hemodynamic improvement. We were able to taper off inotropes. She was needing slightly lower levels of oxygen. However, the sensorium was struck. There was no improvement. She was same irritable and confused. There were persisting hiccups. However, we observed that there was some new onset stiffness in the jaw, and some repetitive jerky motions of both upper limbs as well as lower limbs, sometime involving the trunk. And there was also grade 2 rigidity in the upper limbs, and the deep tendon reflexes were also brisk. We thought something was happening with brainstem, but we are not really sure what it is. We are also not really sure whether that was some seizure activity. So we added anti-epileptic drugs, and we also started her on midazolam infusion. As her airway was threatened because there was continuous accumulation of oral secretions, we discussed with the family, and then we had to electively intubate her. And at the same time, after intubation, we sent the ET secretions for cultures. Subsequently, we got further investigations. The EEG showed changes suggestive of encephalopathy. There were no epileptiform discharges. A contrast MRI brain was performed. There was nothing major which could be discerned except for some small vessel ischemic changes. And then we thought we might as well get the CSF analysis also done. So at that point in time, we had certain possible or probable causes. One was infective, or something to do with in and around the brain tissue, or likely, as was guessed by a neurologist, maybe carcinomatous meningitis. However, our ICU team has also pointed out that maybe this could also be because of certain cancer drugs. Doctor, why don't you check it? And they suggested that maybe Palbo can also cause certain neurological adverse effects. So I would like to ask Dr. Pradeep, your experience with palbociclib, and did you observe any of the neurological adverse effects in your practice?
Palbociclib theoretically can cause neurological adverse effect, but practically I haven't seen none, neither in the peripheral nervous system nor in the central nervous system. Particularly in a patient who is responding to palbociclib, I have not seen any neurological adverse effects. Thank you.
No. Dr. Pathak, sir?
Yeah, I agree with Dr. Venkat. I think palbociclib has been a relatively safer drug as far as the neurological complication goes. So I haven't yet seen anything of this sort.
Correct. I think as oncologists, we have used plenty of this drug, and we really don't recollect any of our patients having some sort of neurological adverse events. But since it was pointed out, we thought we might review the literature, and we could find that though on a rarity, palbociclib can still cause this posterior reversible encephalopathy syndrome, which usually presents with certain headache, confusion, or maybe seizures. Or very rarely, it can also cause the thrombotic microangiopathy, which can present with transient ischemic attacks or stroke-like episodes. However, there is enough literature which says that patients can have psychiatric illness, more so in the form of mood disturbances, that patients, about 10 to 15 or sometimes 20% of the patients on longer duration palbociclib tend to be depressed, some of them having suicidal ideation also, and some rarer autoimmune encephalitis because of palbociclib. So, since our patient was also not fitting in any of this, and we were really, struck what clinical picture is happening with her. So, the literature review for palbo-induced encephalitis, we found it was interesting because this sort of picture usually happens with the use of immune checkpoint inhibitors, wherein some autoimmunity is triggered against this AMPA receptor, but with longer usage of palbociclib, sometimes some patients tend to have this inhibition in the CDK4/6 pathway, especially in the T regulatory as well as CD8 T cells, which might actually trigger, autoimmunity against this particular antibody. Now, this has got certain predilection in that it usually affects the limbic system, so it usually presents with ataxia and nystagmus, which we did not see or observe in our patients, and it has also got some findings in the MRI, whereas for our patient the MRI was negative. So we thought this was also not a possibility. So what happened then was that she was needing the midazolam infusion for as continuous infusion, because the moment we tried to cut down on the infusion, she had this recurrence of hiccups as well as the myoclonic jerks. Meanwhile, some of the investigations have come, that is, the cultures have turned out to be negative, luckily. CSF, both for infective, that is, gram stain, culture, AFB, fungal stains were all negative. It was also acellular, there were no malignant cells seen. And even on the biochemistry, there was nothing abnormal. We also sent the CSF for infective panel, which is a multiplex PCR panel, that was also negative. And we also evaluated CSF for some autoimmune encephalitis panel, that was also, however, negative. So, despite that, despite all these investigations, nothing was leading us anywhere. We also wanted to check what's happening to her disease status, and so we thought we'll do a evaluation, and CT chest, abdomen, pelvis was done, and again it reinforced that the disease is still under check. So with this information, infection was grossly ruled out. Neither is this carcinomatous meningitis. Palbo-induced encephalitis is also not fitting into it. So I really wondered or shocked or perplexed, what else could this be? So we had a discussion again with our neurologist, the ICU team, what the other possibilities were. Should we give her a trial of steroids? Now that steroids on a higher dose also provokes a risk of the flare in infection. So it was really confusing and difficult situation for us. Now, towards the end of the day, we had another attendant who has come, and he says that our patient has traveled to her hometown prior to this admission episode. Prior to the admission episode at the outside hospital, also, she has got some issues with her older brother, most likely related to the finances, where she had some argument, altercation. There was something physical also, sort of like gagging, and some serious verbal threats to life also. The attendant then says that she has noticed difficulty in speaking. There was some hoarseness and swallowing difficulty. And on the next day, she was having these hiccups, and she eventually developed fever, confusion, and because of which she was admitted to the outside hospital, which was nearest. He also says that some legal action was, the case was registered 4 days prior to coming to our hospital. This is the additional information he has suggested. Dr. Karishma, in
Yes,
terms
sir.
of abuse in elderly,
Yes.
do you think it's quite common, or the patients don't bring it up, or how do you see this?
So we have certain scales, sir, which we use for abuse, picking up abuse in elderly. One of the most common scales which we use in our hospital is EASI, which is Elder Abuse Suspicion Index. It's a 6 questionnaire where the first 5 questions are essentially, asked to the attendant, where we also noticed whether the patient is feeling withdrawn, whether the patient is avoiding eye contact, and asking certain questions about financial security, social security, and at the end, a thorough examination, which involves head to toe examination, like bruises and pattern bruises, which do not match the given history. And since one of the most common things is fractures which are not, associated with osteoporotic fractures, which are not, especially bruises in the trunk, in the abdomen, and certain examinations like that. So that is an elder abuse suspicion index, which we do. And after this, then we do certain examinations and certain testing, such as that area. For example, if there's an osteoporotic fracture, we would essentially look at hip fracture or bone fracture, but we look at bilateral lower limb and a history which is not matching. So that is something which we focus on in elder abuse.
Yeah. Dr. Dharshitha, where do you think this abuse happens, at home or in the hospital? Uh, you know,
So I've seen both the types, things that have happened at home and also in the hospital. So there were instances where the patients were brought, and so this was predominantly at my previous workplace. They were left without any attendance, and there's nobody to take care of them. So it can happen in virtually anywhere. So at home, it's predominantly neglect in the form of not addressing their basic hygiene issues or food or medications. People who have had falls and they were not brought to medical attention or to the nearest hospital for any immediate care. Later, at one point, when we saw a lot of healed abrasions over their skin. So it can happen at any place. So in a typical OPD setting, you always see the caregivers who are not letting the patients themselves speak, but they try to interrupt in for every question that you ask them. So,
So how do
so
you
these
how
are
do you
certain.
how do you actually intervene, or from your side, how do you think that you can try to correct these, or you know uh, or the preventive
Uh,
measures per se? Yeah.
Yeah, so when it's an unfortunate aspect that, suppose if we raise these concerns and we try to report them, these people have nowhere else to go. So it's always important that we actually, align and address them in a private setting. You speak to the patient first independently and then bring in the caregiver later and understand what are the exact concerns they're facing with and try to resolve within the hospital setting. But in extreme cases, it's worth reporting. But probably in Indian, I mean, in Western situation, it's a different setup. But for us, I think most of them are dependent on their children. The very few who are actually still affordable and able to live independently. So considering the social factors, it's an important thing that we'll have to address each case individually, sir. So, and again, the signs of abuse is also not very classic always. So, as per literature, there are some instances where you see any abrasions or bruises across your face, cheeks, zygomatic areas, or on the back, on the ears. These are certain sites which are typically, relevant to elder abuse. Like this is actually, we'll have to have more evidence on for children we have, but we do not have specifically what are the classical signs of elder abuse, considering patients being on antiplatelets. Uh, you have bruises at different sites. So in that way, the typical presentation should always be looked into very carefully, sir.
Yeah, what actually happened was that that other brother had actually come to the outside hospital. He had some, you know, dramatic issue or scene created there, and then that's the reason why they again came back to our hospital. As you said, that it can happen anywhere. Yeah. So when we look at literature again, the WHO 2024 fact sheet, though the numbers reported here across various types of this physical, psychological, financial abuse, I think it is still underreported, and it is significantly higher than what is being shown here. And even in the Asia Pacific region, we can see that the documented prevalence of abuse in elderly is somewhere reaching up to 30-40%, with the abuse being more common in females than males. So again, these are certain cues for potential abuse. So what we can see, if it is physical, then maybe we can see, as was enumerated by the other panelists, but we can also make subtle impressions on them, whether they're based on the nutritional status or the hydration status, which all point towards the neglect that the patient is going through, or sometimes the behavior of the older person or the caregiver. It takes a little more time and observant eyes for us to pick up those cues and find out or to inquire more whether this particular thing is happening with the patient or not. So now with this particular information, so we thought something else, and though brainstem injury, I don't think so. Physical sort of gagging sort of thing will cause some brainstem injury, but we had a thought whether something like poisoning was done to her. So what we did was we planned for an MRI whole spine screening and also send additional blood work for toxicology. However, we also wanted to do a repeat CSF cytology because we might miss the malignant cells on a single sample specimen, and we also wanted to rule out paraneoplastic syndromes, which is again a rare possibility. So on day 3, the ET secretions of cultures has grown as Acinetobacter MDR. Her antibiotics were modified. Luckily, the MRI whole spine screening was normal. And after thorough discussion, we thought that we might give her a trial of methylprednisolone. And over the next 4 days or 5 days, we completed the course of methylprednisolone. However, there was no respite in neurological status. She had persistence of these jerks or continuous hiccups happening on any attempt to taper the higher midazolam infusion rate. The neurologist escalated the antibiotics, and she was actually on 4 anti-epileptic drugs. The repeat CSF cytology was also negative, and she was planned for an elective tracheostomy on day 7. On day 8, however, the serum paraneoplastic panel was positive for this anti-amphiphysin antibody. Now, Dr. Dipen, if you are here, or Dr. Nihanthy.
Yes, sir.
Have you come across any of these paraneoplastic neurologic syndromes, or
Sir, I have seen one patient in my residency who actually presented with stiff person syndrome.
Okay.
Yeah, and in her case also this turned out to be positive.
The anti-amphiphysin.
Yeah, anti-amphiphysin has positive in her case. So
Yeah.
this is something more like encephalitis with myoclonus and rigidity both combined together. So the
Okay.
presentation is it's quite complicated. Like you won't think as a paraneoplastic syndrome.
Correct. It's quite rare, and
Yeah.
when I went through the literature again, it was 1 in 1 lakh metastatic breast cancer patients actually have the stiff person syndrome or this sort of neurologic paraneoplastic manifestation.
Actually, this was the case in whom I could see a sternal biopsy being done also, sir, because we didn't have any conclusion, no breast lump, nothing.
Okay. Right. Just to understand what usually happens is that because of the tumor neoantigen exposure, whenever these dendritic cells or antigen presenting cells process them, there is some cross reactivity to neuronal antibodies, which damage the neurons. And this manifestation can occur in varied ways, like the encephalomyelitis or the sensory motor neuropathy, opsoclonus myoclonus, cerebellar degeneration, or the myasthenic syndromes. For our patient, it was matching or fitting into the major criteria, that is the rigidity, triggers for spasms, and encephalopathy, positivity for anti-amphiphysin antibody, encephalopathy on EEG, and nothing else picked up on additional CSF or radiological evaluation. So it fit into this particular major criteria. So a final diagnosis of progressive encephalomyelitis with rigidity and myoclonus, which is actually a severe variant of so-called stiff person syndrome, was diagnosed. However, the one of the treatment for this is steroids, and unfortunately, our patient was refractory to that, in that she did not improve on that. The next set of treatment for that is a higher dose of IVIG, that is 2 gram per kg over total dose split over 5 days. And I think it worked like a wonder drug for her. On the second day, she was getting better. The stiffness, rigidity was better. We tried cutting down on the midazolam infusion. Her sensorium was okay. She was conscious, alert, was able to understand with sign language. So eventually, we completed the IVIG course, and on day 10, we are able to cut down or stop the midazolam infusion, and we started the ventilator weaning. On day 12, we extubated her. That time, the toxicology screen has also come, and it was negative. She was needing 4 liters oxygen. We initiated physiotherapy for her. On day 16, she was shifted to the ward. Since that, the autoimmune encephalitis panel was negative. We thought we'll re-challenge the CDK4/6 inhibitor and see what happens while she is still in the hospital. Fortunately, she tolerated that treatment well and she was discharged to home on day 25. She was ambulant, needing some support of oxygen, and as per the advice of neurologist, she was sent home on tapering oral steroids. So we reported this case since it was quite rare occurrence. And I think we started with one of the commonest presentation in elderly in this case. We discussed abuse in elderly, the rarer side effects of palbociclib and neurological manifestations, which was quite rare to end with in our patients, and successfully we were able to send her home uh, in a better shape. Right. Now we move on to our second case. So he is another 90-year-old gentleman. He had a good ECOG performance status. He's a retired central government employee. He's a widower. He's got three children, all of them married, settled abroad. His elder daughter is a medical practitioner in US. He has got a full-time domestic helper, with the help of whom he manages things. And he has got a great pair of friends, two friends actually. I recollect, I remember them, and they accompany me all the time. Now he has also got hypertension, diabetes, insomnia, a dyslipidemia for which he is on medication. He was also found to have some depression, which was diagnosed recently, about 6 months back, for which he was started on mirtazapine. He was doing well till February 2024 when he was observing some pain in the epigastrium or right hypochondrium. And he was also saying that he had decreased appetite and maybe weight loss also, 3 kgs. So his family physician did some evaluation and then suggested him to get an endoscopy. Maybe you'll be having some gastritis and also might as well get an ultrasound scan done. Unfortunately for him, the endoscopy showed growth in the cardia of stomach. The biopsy reported as poorly differentiated carcinoma. We did an additional ISC, which was positive for synaptophysin, chromogranin. The Ka67 was high. PAN-CK was positive. So final impression of large cell neuroendocrine carcinoma was made. So with the biopsy report, he has come to a hospital. We did a staging workup for him. We got an FDG PET CT where the primary lesion was identified in the stomach and there were bilobar liver metastasis. There were also nodes which had disease. So the final impression or diagnosis for him is stage 4 large cell neuroendocrine carcinoma of stomach. Dr. Pathak sir.
Okay.
Yeah. Principles of management for this patient, or how do you look at, or how do you manage large cell neuroendocrine carcinoma?
Yeah, but I don't think this is a run-of-the-mill case of, stage 4 or extensive stage, maybe small cell carcinoma. 90 years of age, though you have said that he is ECOG 1, but definitely we'll have to take it with a pinch of salt because many a times what we have seen is that they do appear to be very, ambulant and in good state. But the moment you give them the first cycle of chemotherapy, then they don't they don't have enough reserve to come out of it. So in such kind of case, definitely I try to do those geriatric scales, which has been talked about. But frankly speaking, I would rather go for maybe an oral etoposide and not have the courage to give him, paclitaxel or paclitaxel, which is the ideal treatment in this kind of case. So maybe I'll be slightly conservative and just go for maybe an oral etoposide.
Yeah, though it is morphologically large cell neuroendocrine, but I think we usually manage like small cell
Small
carcinoma.
cell, yeah, yeah. Mhm.
And what do you think is the prognosis? Leave apart his age, if it had been
Mhm.
some 40, 50-year-old gentleman. So
So
what do you
see,
think?
Yeah, now you have a very rapidly dividing tumor with a high Ki67, Though we know that small cell are do have a, and extensive stage, or those patients do have a bad prognosis, but they also do respond to chemotherapy because of their high proliferative index. So I would rather give him first cycle. If he would have been young, I would have given him the complete cystitoposide and, um, hoped for the best. Maybe in today's world, we can also add an IO to the patient, and we could have added an atezolizumab also. But we all know that this is a very, very bad disease to have.
Yeah.
So prognosis is generally grim.
Yeah. Dr. Pradeep, what would be the expected survival for this patient? Not for the 90-year-old gentleman, but in case if it had been a young patient, if you had offered treatment.
So, as Dr. Pathak sir said, small cell carcinoma is quite an aggressive disease, and although it initially will respond to chemo, we expect a very early relapses. That's what particularly what we see in small cell carcinoma lung as well as the extrapulmonary sites as well. And once it relapses, the prognosis will be uniformly poor because we do not have much options as well. So in this 90 years old, maybe we will not be able to give the standard chemotherapy. So as Dr. Pathak sir said, we'd like to do certain assessments because at 90 years, just because of the age, we should not deprive them of chemotherapy because when we are taking decisions at such an age, there are three factors that comes to my mind immediately. One is the biology of disease. For example, this is small cell lung carcinoma, which is extremely sensitive to chemotherapy most of the times. That is one factor. The second is the patient factors like the G8 score and other factors which we have discussed, the frailty score, etc. The third one is what the patient and family wants, the shared decision making, because ultimately it is that factor that will take the lead in this population. Because let us say we give a very good treatment as well, if they don't have adequate social support, they will succumb to the side effects. So these are the three important factors that comes to my mind. So these factors I will consider before taking decision for this patient.
Correct. Thanks, Dr. Pradeep. I think again, as enumerated by you, there are patient-related factors in terms of the comorbidities, its life expectancy, geriatric syndromes. What does the patient want, or the aim of treatment, or the preference or goals for him? Again, the disease-related factors like the type of the disease, whether that's a chemosensitive disease or not, burden or symptoms, and the treatment-related factors, toxicity, whether the intent is curative or palliative, the logistics involved in treatment, social support, finances, family's willingness. So all these probably play a major role in whether a, a particular disease or a patient can be treated or not. Dr. Nihanthy, these questions for you. What do you think is the recommended minimum practical assessments required for assessing vulnerabilities in elderly cancer patients?
So we have various tools for that. We have the comprehensive assessment panel, but I think in my clinical practice, the maximum which I do is I think only the G8 score, which is just done in 2 minutes, where you look into the 8 factors where your BMI, weight, nutrition, whether the mobility, everything is taken. But yeah, there are multiple scaling systems are present, sir. One is the daily is there, CRGs and other important scoring. So many things are there, but to be as my both panelists have discussed very well, I see the number of cases are quite less, and I totally stick to the G8 per se in my clinical assessment, sir.
That's a screening tool, right? So,
Yeah. So that's the only thing I'm quite aware of.
yeah. So at least the ASCO guidelines recommend that we do minimum assessment of estimating the life expectancy for this patient, and do some functional assessment, and that is doing IADL and Charlson Comorbidity Index or some other comorbidity assessment, and also identify or screen for falls, depression, cognition, as well as nutrition. And if any treatment is planned for him, like that of chemotherapy, do some sort of toxicity assessment. So this is the minimum data set which has been suggested by ASCO whenever we treat uh, cancer in elderly patients. So, Dr. Pradeep, why do you think we need to do a comprehensive geriatric assessment? Why not do some sort of simpler screening methods?
Because the biological age is not the actual age which we see. And if we depend upon only that normal age which we see, so we may miss out many patients who will be otherwise be fit for the standard therapies. In the same way, the opposite is also true. The patient who are seemingly fit for the therapy may succumb to the therapies when we give it the standard doses as well. That's where the COG scores as well as the CGA comes in.
Yeah. So that indirectly helps us, to identify problems which are not routinely identified by history and physical examination. It will help us to estimate the survivals in patient, helps in making treatment decisions, and also make an assessment about the toxicities or make attempts or identify domains where we can make some corrections so that that particular treatment is more feasible or compatible for the patient, and predicting some of the complications, or as the patient is in the process of treatment or he moves forward, we can pick up new problems which are not present earlier, so that overall the care is more better effective, so that it is more fruitful for the patient. So these are some of the domains which are usually looked in. For the function related domains, IADL, comorbidity, Charlson's or CIRSG. Falls, it's simple single questionnaire. For depression, we use the GDS short form score. For cognition, the simpler one is the mini-cog, or you can do the MMSE. Some nutritional assessment and toxicity assessment. For solid tumors, we use this CAG, and for hematological malignancies, CRASH. So these are some of the things which we can do.
Dr. Nikhil, I just want to bring in a very practical point.
Sure.
Like I don't know, all of us use this app called Onco Assist.
Yes, sir. I think
Yeah,
that's a great app
yeah, that's
because
a great app. Yeah.
it covers
So
majority of this.
yeah, so and at one go, I think it hardly takes 2 or 3 minutes, and you have most of the reports there.
Information ready.
Yeah,
Yes.
yeah,
So
yeah.
we tend to complete the IADL in that,
Yeah.
Charlson comorbidity index in that,
CAGR,
all
falls, everything. I think most
mini-cog,
of it is there. Yeah.
BMI, we have got car crash in that. So I think it does
Yeah.
excellent job. Yeah. So if anyone is not using, I think I recommend using that job, so that there are only hardly 2 or 3 tools which are not there in that, and that we can
Correct.
add up later. So what's the geriatric assessment for our patient? So his BMI is okay. Uh, his nutritional risk index, which again was part of that OncoAssist app, which predicted that there is severe risk of malnutrition. The G8 screening suggested that he needs a full comprehensive assessment. The age-adjusted Charlson Comorbidity Index predicted that his 10-year survival is 0%. And the uh, chemotoxicity score is 12, which means that he is highly prone to experience some serious toxicities. On the functional domain, that seems reasonably okay in terms of ADL and IADL, where he was able to perform majority of the activities by himself, and there were no falls luckily for him. In terms of the cognitive domain, again, this was also reasonably okay. He had no impairment in terms of cognition. However, on the geriatric depression scale, he had mild depression, which was already known. He was already on medicines for that. In terms of the organ reserve, his hemoglobin was 10, creatinine clearance was moderately reduced, 47 ml per minute. His cardiac function was also fairly okay. Now, with this information, uh, Dr. Pradeep, what would you like to do?
So we have seen this score where he is very much vulnerable. VS score is very less, as well as uh, the COG score also indicates that if we go for the standard therapy, standard dose of the chemotherapy, there's a high risk of toxicity. So in this patient, usually like in all other protocols, where we'd like to give a lower dosage as well as for a brief period, the short interval chemo, that's what we need to discuss with this patient because as we discussed, there is only one helper with him, full-time helper, and he is dependent on him for any side effects and other needs post chemotherapy. So he will not be fit for the standard EP chemotherapy in this, like we do in younger patients.
Dr. Nihanthy?
I also totally agree with Pradeep sir. So, if you're looking at various scales and especially the frail scale also, so it indicates that he may not be a candidate to tolerate the full course of 3 weekly etoposide or platinum also. And clearance is only 47. So, as even Pathak sir mentioned, maybe oral etoposide is one of the option which I would consider. But I think I would discuss this case with his family, like what is his family expecting? How are his caregivers? If you're giving any full dose of chemo, who will take care about the toxicity per se? And a proper holistic approach is what I would look into it, sir. Only when everything is covered, maybe then I can be aggressive, or else even I don't think I'll be aggressive in him.
Dr. Siju, are these the tools that you routinely use in your practice or anything else?
For this comprehensive geriatric assessment,
Yeah.
yeah, definitely. For there's a multiple domains in that. That is for the most of the medical assessment that to assess the polypharmacy. And all we have discussed the Charleston's comorbidity index.
Yeah.
Then comes the psychological things, JDS. That's short form only. That is JDS 15 or something like that.
Yeah.
Then comes the various parameters like the nutrition assessment. Then accordingly we should also monitor the visual status, hearing, all these parameters to also to prognosticate, also to know about the complications associated with the chemotherapy and all.
Yeah. Thank you. So I think treat versus not was the great difficult question for us. So we discussed this initially with her daughter who is a doctor and a friend who accompanies him. So we discussed the incurable nature, the palliative intent of treatment, what actually this disease demands in terms of treatment, the outcomes with or without treatment, his assessment findings, what we are going to achieve with treatment or the toxicities or side effects of treatment, and the option of not actively treating versus doing only symptomatic supportive care. We also discussed not the entire thing or some things with the patient because he was quite literate and understanding about his condition. So we explained about the problem, the disease, what actually are the treatment modalities for that, the good and bad in his existing health condition, the option of doing something or not is what we have discussed with him. And he said that he needs certain time to analyze, process this information, and maybe take a final decision on what to do or what not to do. And then he has come a couple of days later, but then he has come back with more questions. And he asked, Doctor, do you know for sure that this particular disease behaves the same? Or if you treat, that it responds the same in me, like that in the young patients? And the second question was that, are these assessment results of yours mean that I should never try the chemotherapy? Or if I say that I want to give it a try for whatever, now do you have any plans so that I move in that path? Dr. Patak, the first question.
Very difficult question to answer. I think
So I was really
one
taken back
thing,
when he asked.
so one thing is for sure that if we are looking just at science, and
Yeah.
we are looking at the biopsy report, a highly proliferative disease should respond to chemo, be it young or be it old. I would rather, just to answer that question,
Yeah.
I think with that particular biopsy report, I would say that, yeah, it should, in
So
fact, the
biologically,
chemo.
it
Yeah.
should behave or respond the same, is what
Yes.
you feel.
Yeah.
Yeah.
Like,
Dr. Pradeep, the second question.
Yeah. So, continuation of the discussion by Dr.
Yeah.
Pathak, sir.
Yeah.
So definitely, by logic, yes, he should respond. But if he asks for data, because um, obviously his daughter is a physician in
Yeah.
US, so
Yeah.
if she asks for data, we will not have data
Yeah.
because most of these patients are excluded from the clinical trials. There is never a clinical trial for the ECOG patient with a altered
I think the
creatinine.
first question was actually he was asking about science, whether
Yeah.
Dr. Science. Yeah.
Yeah. Second option, the second question, does this mean that we should never ever try the treatment? No. It doesn't mean that, but we should be very careful. If we go for standard treatment, maybe we'll go for altered doses as with altered schedules. That is what it implies. That's
Okay.
how I explained. Yeah.
Dr. Nihanthy, the third question.
Sir, I totally agree with both my panelists, sir. Actually, it's a little dicey and a tricky situation. If you just focus on the tumor biology, I think I would say yes, go ahead and treat. But yeah, there are other factors, but we can't, based on these factors, deny a patient treatment also. So if he wish to try, then I would explain him the toxicity of chemotherapy involved. So is he willing to take up the toxicity, because that can hamper further quality of his life. Whatever mobility he's having also can be hampered. Is he willing to take a risk? I think I'll ask the patient and the patient's attendant in detail. Like if something goes wrong, who's going to be around? Who's going to take care of the feeding part, all those things. And if I get a quite satisfying answer, I will definitely tell that I have no issues against any treatment. But yeah, maybe being aggressive is the only thing I'm a bit skeptical. I'll definitely treat him, but should I be aggressive and go with the normal plan, or should I reduce the dose, is what I would discuss with him.
Sure. So I also had the same doubt on what treatment options do I have actually got. So the standard answer, platinum doublet chemotherapy. The other option is immunotherapy. Again, no straightforward data for its use in small cell or large cell stomach, but an extrapolation from other sites. The third is the radiotherapy, which is prophylactic cranial irradiation done at a later point in time, which I think is a far-fetched thought to bring it in for him. So then
Other thing I think I will add to his symptoms also, sir. I would look into his symptoms. How aggressive are his symptoms also? Because if it's a highly tumor responding disease.
yeah.
So what symptoms, and does he have anything major
So he's
causes?
got pain as well as loss of appetite and weight loss. Yeah, he
So I'll
was needing
explain, I
some
think. Yeah,
he
I
was
think
needing some stiffer doses of opioid analgesics also for pain. So
I'll tell him very clearly that I'm not going to deny the treatment, but these are the parameters which I would look prior to the treatment per se.
yeah. So for the first question, I thought I'll just review some literature and then I found this interesting article which looked into the small cell lung cancer patients who were more than 80 years of age. So this was, however, a retrospective analysis. 146 patients was analyzed. The median age was 80 years. This included both limited and advanced stage disease. However, here we can see that about 30% did not receive any therapy, and about 45% received some chemotherapy, and about only 20% of them received combined modality therapy. You can see that the median survival was 5.4 months, and some split, like it was only 1.5 months for those who did not receive any therapy, versus 6 or 7 months for those patients who received chemo, and about an year in those who received both local and systemic therapy. So again, the same can be seen in the
Sorry,
Kaplan-Meier.
so which just one question
Yeah.
in this data,
Yeah.
Which countries were taken into consideration? Which country was this study done in?
I'm not really sure.
Because that makes all the difference.
Yeah.
Because low middle income countries like ours have the functionality above 80 is much lesser when you compare it with an English Caucasian population, for example, a high income country like UK. So
Correct.
their
Yeah.
functionality is already amazing. So that is
Here
something.
also you can see that about 45-50% of them had good ECOG PS, which I don't think so is possible in our set of patients. Yeah. So same again is being seen in this Kaplan-Meier survival curves, that those patients who received treatment lived longer, and both modalities of treatment, the median touching up to an year. So again, the analysis confirmed that chemotherapy is quite active, beneficial. However, caution must be exercised in very elderly patients that they might not tolerate the aggressive multimodality therapy. So after assessment and careful monitoring, maybe you should individualize your treatment plan, is what they have suggested. So I've gone through and analyzed or checked for the various dosing schedules, though I'm pretty sure that the standard dose is not an option for us. So when I looked at literature, there was this study which looked into the split dose of cisplatin and etoposide. What they actually did was they replaced carboplatin with cisplatin. Cisplatin was split over 3 days, and etoposide was again the same. I thought this is also not a great option for our patient. So what else? What else can be done? So I found this interesting abstract, which is from AIMS from our country, where they retrospectively analyzed small cell lung cancer patients from 2018 to 2020. Here, they had some information regarding patients who had advanced stage as well as poor performance status, PS3, PS4. So what they did was that they started these patients on weekly chemotherapy, that is etoposide 60 to 80 mg per meter square, as well as carboplatin AUC2. So the numbers were small, but I would say that they had some symptom palliation, or in fact had partial responses, and one patient had stable disease, which again is for a shorter duration of time, but that is what usually happens in small cell lung cancer patients, even in the young. So I found that this approach was one thing which we can try maybe in our patient. So out of all the three options, I thought, okay, we shall discuss this weekly carboplatin AUC2 and etoposide. And the second question was, is real immunotherapy effective for elderly patients? Uh, Dr. Pathak sir, how would you
I don't.
see? Yeah.
Yeah, if you go by the basic genesis of immunotherapy, I think at the age of 90, how much active T lymphocytes would be there to take care of malignancy per se? I'm not aware of the data, but the basic common sense, I feel it shouldn't be all that effective and a very elderly individual.
But again, so the data is other way. Otherwise, I'm not.
Maybe I'm not aware. Yeah. So,
Yeah.
so
So I
what
think
does the data say? Yeah.
the data says that it is active in terms of the duration of responses or the PFS across studies. So
Okay.
this sort of meta-analysis which say that both PD-1, PD-L1 inhibitors in older adults across disease uh, is active agent. So irrespective of
Uh,
age, so it is okay to use them for whatever benefit they offer.
Single
And
agent.
no,
Single
sir,
agent
whichever
immunotherapy.
combination you use or a single agent in an approved setting,
Okay.
wherever indicated. Right. So then the third question of the radiotherapy PCI in elderly, I've gone through literature again. Again, the data is all divided for that. Uh, However, majority are of the opinion that there is a definite benefit in terms of survival for those patients who have responded to chemotherapy. But there are also concerns about toxicity in elderly. So, despite all the newer modalities of hippocampal sparing surgeries or neuroprotective agents, memantamine and all, uh, there is no clear recommendations for its use in elderly or very elderly population. And the data is also all over the place in terms of why don't we do some serial MRI scans uh, and then act on it whenever you find disease on a scan rather than doing it early in the course of illness. So I think PCI is down on the cards, last on the cards, and I thought I'll leave that question for time to answer. So what we did with our patient was, after a thorough discussion, we started him with single agent of carboplatin AUC2, and he tolerated the first dose well. So we added etoposide from second week onwards. Uh, for him, he had some logistic issues with immunotherapy, so that question was sorted by nature, and he was needing some supports once in a while, maybe 1 or 2 GCSF injections, and every alternate week or once every 3 weeks, he needed some romiplostim for his marrow to recover. But we were sort of fairly were able to deliver his weekly doses at comfortable, reasonable pace, and he was also tolerating it okay, I would say. So after 9 weeks of treatment, we got a PET-CT done again. There was good partial response. He was happy. We were happy. His pain was better. His weight stabilized. He was okay. And then we continued with the second phase of treatment and completed 9 more weeks of the same. And as is the situation, when we got a repeat PET-CT done, there was disease progression, more so in the liver as well as additional mediastinal nodes. Now, Dr. Pradeep, what would you like to do or discuss with your patient next? Dr. Nihanthy, if he's not around.
I think now too it's a very clear-cut indication of progressive disease, sir. So I think I'll tell the patient's attenders at least that disease is not looking good. We thought he would respond, but he's not responded. So it indicates it may be quite aggressive, or maybe the treatment which we have given, it's not quite like appropriate also, but still he's not responded well. So I would conclude saying that prognosis is not that good. At least at this juncture, I would tell the family that it doesn't look uh, a nice picture. So it looks more like prognosis is quite bad in his case.
Would you do a repeat CGA now and then make a fresh look?
I think that part I'll definitely take care. So if you're only talking about the disease is quite refractory sort of within 18 weeks. So it's become like a progressive disease. But I'll again look into his performance status, his CRGA scores and all. Then
And
assess.
yeah, and what if all the scores are like that of at the time of beginning? They are near same.
So again, I think I'll explain in detail to the families. Like I want to know what the family wants. Is it a symptom care, or they're trying to prolong their life? What exactly is their intention? I would consider. Based on that, if they say that, okay, they are willing to take up the toxicity, then I would plan even the second line. But if the family says that, okay, he's doing quite fine now, performance status has improved, symptoms have improved. So
Now,
let's like
now
make
since the
them.
disease has progressed again, his pain has come back.
Okay. So
Yeah,
pain
no,
is
that,
main issue, then I would tell them like, see, there are options of analgesics to be for him to be given only for pain control. So this is the time I think I will speak about whether the options of a second line versus just supportive care or pain management to be taken into consideration.
yeah. Dr. Pathak sir.
Best supportive care.
So
I think his 90 years, we have already given him the best. He has progressed.
But I
I
think
think,
I'll give the option to the patient and the family to
yeah.
decide.
Yeah, but in heart of heart, I think
So heart of
might of
no,
might.
our patient was not that easily giving up guy. So he was really looking for some more treatment, if it's available or possible.
So, like second line, I have not taken. I would not be very comfortable. Maybe, as I told you, I would just go for an oral etoposide. That's it. Nothing beyond that.
All right.
Might take. Yeah.
Yeah. So he said that he was ready for next set of medicine also. So there were no standard answers or answers for his particular stage or situation right then. So we started with weekly paclitaxel, 60 mg per meter square. We gave him for about 6 weeks. We got a repeat scan done. It showed stable disease, but this time the paclitaxel was, hampering his health. He was having some sort of myalgias. His fatigue also worsened. So that is when we had another discussion, and then we thought that it is better we stop doing chemotherapy at that point in time because his quality of life was getting spoiled, and then do only symptomatic supportive care. So in Jan 2025, he had some bleeding issues, pain. He was needing some intermittent supportive care admissions, and he was on oral analgesic medicines. And in March 2025, he was admitted into palliative care ward for multiple issues, and he finally succumbed to his illness in March.
So what was the time when he was, disease was diagnosed? Somewhere around?
So it's 1 year, sir. Feb 24 to March 25 is what? Almost
Okay.
10 year. Yeah. Yeah.
Okay.
So I think it was also quite difficult for us to, make these decisions. We are also we're very concerned about the toxicities of treatment, whether we are right in doing, not. What's about patient's autonomy when he's really wanting to do or take treatment. So it was quite challenging for us to, it was quite demanding also.
But then I think you were able to, like,
We were able
he
to,
was able to live a year. Yeah. So
yeah,
not
for
not
tennis.
bad. Not bad.
Yeah.
Mm.
Dr. Praveen, sir, if you are available.
Yes, sir.
Coming to this end of life care discussion, what we actually do, or
Yeah, basically, I mean, see, 90 years with so many geriatric issues, frailty issues. I mean, you tried, I mean, according to science, you tried, I mean, so many things. I mean, maybe first phase, second phase, progressive disease, and third phase also you convince the patient. But as a palliative physician, I always think about the quality of life in these populations. Mostly, if you ask me at the progressive disease stage, definitely I would have preferred the supportive care only. Because this 1 year, maybe he gone through a lot of things. So patients and the family, multiple hospital admissions, weekly admissions, hospital acquired pneumonias, transport issues, logistic issues. I mean, definitely the quality of life definitely it's impaired during this entire the 1 year of journey with the progressive disease. So when you refer to the palliative care at this moment, generally what I will discuss with the patient and the family member, even though educated, about the quality of life. So how we go next life, like so I will involve the psychologist to assess the psychological status of the patients, what he wants at that moment. Is there pain relief, or is this prolong their life, or is that any last wishes for him, or whatever he wants we'll try to do, and we'll discuss with the patient family members also about the goals of care and everything. And we'll use some prognostication scales for each and every our patients, so to know the time period. So based on that we will take the care plans also. And so we will ask the patient's autonomy. So is there any advanced directives at this moment? If the patient is conscious and coherent, yeah, as you said, is very motivated, is a fighting in nature. So we'll ask the patient about where he wants to, I mean, based on our psychological interventions, so where he's comfortable at home or at hospitals, and we'll discuss with the family members, and we'll take the any advanced directive if he's able to give the advanced directives. So based on that, we will care for the final stages of the life at home or in the hospital. If at home, we'll give the attached to the home care services, and with the regular follow up with the patient attendance, we'll take care of the patient. In the hospitals, we'll try to give the medications to make him comfortable. And one more question, Dr. Nikhil. Actually, maybe see if even in the progressive stage also, still if you ask the patient and the family, even though educated, every patient family wants some sort of treatment to improve the lifespan of the patient,
yeah,
even though patient is 90 years progressive disease.
they feel that they are not doing something which has to be done or
Yeah, yeah.
something.
So
Yeah,
that should we should address actually. See, elderly population, they're highly vulnerable to the stressors. Because I saw patient whenever the oncology physicians refer to me, we have very close to the patients and the family, because we are only the patient and family centered, not the disease centered. So they are each and every step of their cancer journey they will explain to me. Most of the families, they repented unnecessarily I given chemotherapy. Unnecessarily I took this decision, even though my physician said there is a 50-50 choices, but I tried. If I have not taken any this chemotherapy, he might have, I mean, maybe some couple of weeks he will be with us. So many this type of discussion happened to me. So,
Okay.
and whenever the disease is very advanced stage, 90 years, all fit into the not undergoing an active treatment, and the progressive disease, there is a lot of cytokines in the body that will again dysfunction all the organs. Um, why don't we tell the patients and the family that if he gives the chemotherapy, definitely his quality of life completely deteriorated, so that they will strongly, okay, our doctor is said the same thing, so I maybe I'm correct whatever
But
tell.
I
If
think it's quite
yeah,
challenging,
yeah, it's practically it's very difficult the
difficult,
situation,
because they'll not be able to make any concrete decisions, because that is how they move along the course of treatment.
Yeah, we need to give the autonomy also. If the patients really wants to do all the things, definitely. So
That's actually a very well said point by Dr. Praveen, sir. But I think right now, as an oncologist, I think we are integrating palliative care in upfront now. I think
Early
even
palliative
before,
care.
yeah, before even start of chemotherapy now, currently when we know that patients and there is a bit of complication, we even include the palliative care team upfront. And so it's like we
They are
discuss.
more comfortable and confident when that
Yeah.
engagement occurs. Yeah.
yeah, yeah, that is the reason early palliative integration, even along with the curative treatment.
Early is one thing I think I
But
would focus on, but
exactly,
then,
ma'am.
sometimes even chemotherapy does do cause symptom relief, even though quality of life may get hampered a bit. I totally agree with you, no doubt. But there are patients, especially in some of the elderly patients, even a small dose of chemotherapy, they are very comfortable also. So I think we need to look into both the aspects. I think, as even Purvesa was saying, I think we need to look into as a whole. Just we can't conclude and be emotional about it, just saying that he's quite old. So let's not treat him, that part even I wouldn't agree. I
Yeah,
think,
that's
yeah.
absolutely fair concept actually. But that is the reason if you incorporate the palliative triggers in our hospital,
Yeah.
because in the UK there are clear cut guidelines. Oh, this age of the patient, this comorbidities, this stage of the diseases, this many hospital admissions. This is the palliative care. I mean, they have standardized every
Yes, sir,
treatment,
that's very
frailty,
true.
elderly, gold
Yeah.
picks criteria. If we establish that palliative triggers or the indications in our hospital setting with early integration, so definitely
What
we'll.
we lack, I feel, is early integration. That's what I feel. So I think
Yes, ma'am.
as an oncologist, even I need to be aware that an early integration makes a lot of difference, actually.
Absolutely.
Exactly. I mean, your burden will come down drastically
Yeah.
because we have social workers, we have psychologists, we have pain physicians. So multiple counselings, they will know the what is quality of life, how they will enjoy with symptom free treatment, and we are. I mean, they improve the compliance to the cancer treatment also. If unfortunately, if advanced disease, then completely will take over and preserve the quality of life till the end of life.
Uh, well, that brings the end of the two cases. I thank you all, the medical oncology panel, geriatric panel members, for their valuable insights in management of our elderly cancer patients.
Thank you, Nikhil. I'll just like to add two things, very important things. That when we are talking about quality of life of the patient, I think the expectations of the patient and the family are extremely important, and we are not paying enough attention to them. For instance, if this 90-year-old patient, after the recurrence is there, 1 year after the recurrence, what was the treatment outcome that he wanted? That was not very clear.
Yeah.
So we are, putting our bias into decision making. That is the one point I wanted to make. The second point I wanted to make is that in the UK, NHS is paying for everything, and therefore they have SOPs to decide what to do and what not to do.
Yeah.
In India, it is either the government who is
Don't
paying
pay.
under the free
Yes, sir.
Ayushman scheme, or the patient is paying from their pocket. And today we are in the era of personalized medicine. So we can't say that everybody will have the same SOP to be followed. It all depends on what is right for that particular patient. So I will stop here and hand over to Prem for the concluding statement.
I
Prem,
think
over
we
to you.
had, yeah, I think we had two quite exhaustive cases and discussions. Although we have overshot the time, but I feel that, I mean, it was as complicated as well. So yeah, I mean, elder abuse, I feel, is one of the very difficult things to handle, very difficult to detect, very difficult to act on it. Because a lot of times, of course, in this case, whether the older adult themselves had even knowing about it was there, but there are cases where people don't want to report it because they are like, where are you going to keep us? I mean, it's easier said than done, but they might have the only place to say. And of course, the second case again was quite difficult. Always ideal to integrate palliative care from earlier, but then of course, as sir highlighted, in India, not everything will work. But we obviously have to have sort of a good connect. So yeah, so thanks everybody, and join us for the next tumor board next month. Thank you. We are going to go into the new year. So thank you. Thank you, everybody.